Morning reception, can I help? Okay, that's 9:20 this morning with Dr. Burns.
Chest pain.
Okay, thanks.
What's the problem? It's probably worth ringing an ambulance with chest pain. Your next review's in October, so that's fine. Yeah, we'll put those through for you. Okay, thanks.
The GP consultant model is basically spreading responsibility, if you like, for the patients across the team.
A GP oversees and mentors a team of clinicians who deliver the care directly to the patients.
When we started, demand on the practice was high. You know, the average day, the GPs were busy. They were busy morning, afternoon, home visits, seeing extras. So it's kind of looking at that demand and seeing how we could better manage that.
This was happening in an environment nationally where there was a shortage of GPs and a shortage of nurses. So we decided to look further afield at other clinical models where we could use different clinicians to provide the same care or better care in some circumstances.
The receptionists now work more in the realms of a navigator, and they use some quite, well-researched and thought out processes to direct the patient to the right clinician.
We operate what we call an appropriateness agenda, which is where the patient is seen by the most appropriate clinician for the problem that they're presenting with.
There aren't the GPs there, so we have to appreciate and recognise the staff that are there and the skills they have, and by doing that, people will receive the services they need.
And then we have a team of advanced clinical practitioners, and that's probably been the biggest change in the practice.
The ACPs are responsible for the urgent care clinic, so things that crop up on the day that cannot wait. We also do all the home visits here at the practice, so again all the acute problems that crop up for people that cannot visit the practice. We also take a lead on the end-of-life care out in people's homes, and we also help to manage the long-term conditions, both here in the practice and in people's homes.
I think now, because we've got more GP time available, it's easier for GPs to follow up their own patients.
On some days I work as a salaried GP where I see patients every 10 minutes, I get my continuity of care, but the joy is because there is an on-call or GP consultant on that day, I never get interrupted, so I can concentrate 100% on my patients. On the other days, when I work as the GP consultant or the on-call GP, it means I get lots of time to supervise the rest of the allied healthcare team, the ACPs, without having to worry about seeing patients every 10 minutes. So really, this is the ideal setup for any GP.
The GPs are incredibly supportive. They have protected time out so that when we're running the urgent clinic, they are available to look to for advice, just to run through a plan.
I think in the past, if you think about what a GP was doing in most general practices, they were dealing with acute on-the-day problems that patients were presenting with. They were being asked to do medication reviews. They were doing some long-term condition reviews as well. I think once that workload was removed from the GPs, it freed up a lot of appointments to manage more complex patients with polypharmacy and comorbidity.
Part of the driver for the model was to have happy GPs. Happy GPs make a happy and safe practice.
I think we were met with a little bit of resistance from some of the GPs who felt that there was some work being taken away from them.
GPs are an essential part of the team. The allied healthcare professionals, the ACPs, the nurses, the pharmacists, all they do is add to the team. You wouldn't have a hospital without a pharmacist and without nurse practitioners, so why on earth have we got general practice without them?
If I was to advise a practice on making these changes, first of all, I think it would be very important for them to consult widely with their staff to make it clear to them why the change was necessary and what it would look like when it was all done. Secondly, I think it's important to talk to the patients, whether that's a patient participation group or perhaps just to give some information out there in the community as to why it's necessary and how the change will affect those patients. And thirdly, I think it's important to put some groundwork in, to do some audit work, to look at the workload pattern that's already there before deciding how and when to shift things, because every practice is different.
I think that patients have to have a willingness to change as well and recognise the changes that are going on. And when those changes that are made are proved to be efficient and people are getting treated and they're getting the medication they need, they're getting the services they need and the support they require, they've seen that the model works.
Since the introduction of the new clinical model here, I feel like I'm practicing more like I was when I first qualified than I was 4 or 5 years ago. I feel like I've got more time to spend with the patients.
I can honestly say we give better care to our patients. We treat them more holistically. Our continuity is definitely better. Our access we have proven to be better. If a patient wants an appointment, they get an appointment. And our clinical team is much more satisfied.
Don't be afraid, change is inevitable, embrace it and it'll work for you.
That's fine, yeah, we'll put those through for you. Okay, thanks.